So our first question, Dr. Reiter, is if you can just tell us a little bit about yourself, a little bit about your background and how you ended up, as a neurosurgeon at Hershey.
I trained in Philadelphia in med school and residency. I was at Penn for neurosurgical residency, and there I got my interest in spine. That's where I ended up doing spine. I did an enfolded fellowship while I was at Penn. And then I first went into private practice for a year after I finished my residency, but I really missed the academic part of it, the teaching part of residency. So ended up getting a job at Penn State, where we were at that point just kind of reinvigorating the residency. They had a residency, but it was very small, and it wasn't a department. Penn State then became a department of neurosurgery, and we just have been growing since then. And the residency went from 1 to 3 people. And I've been there for almost 20 years now.
Awesome. Can you tell us a little bit more about the Spine Center at Hershey?
So our Spine Center is a collaboration between orthopedic surgery, neurosurgery, pain management, neuroradiology, and physical medicine and rehab. We have multidisciplinary conferences where we talk about different topics that are of interest to all the specialties. We try to also attend each other's spine conferences when we can, discuss cases and different ways to manage patients operatively and non-operatively. We have a fellowship within the Department of Neurosurgery where you're able to work with different disciplines also during that fellowship. The Practical Spine Center is shared by all the departments as far as scheduling patients, and we try to triage patients to operative and non-operative cases to expedite their treatment. Within the different areas where we see patients in clinic, we try to also co-localize, I guess would be the word, the different specialties so we can discuss the patients in real time, but we also have the conferences where we discuss the patients at other times, and then we'll refer the patients to other physicians or physician extenders as needed. I think we all work well together. Everybody really gets along. There's not one department that really dominates as far as surgery. It's pretty equal between orthopedic surgery and neurosurgery, and I think we both have our strengths. And then as far as the non-operative treatments, the interventional treatments, the same thing. It's pretty equally divided between PM&R and neuroradiology and pain management.
Thank you for sharing. What are some of the exciting new directions that you see in spine surgery?
I think 21st century spine surgery is about preserving motion and not fusing. So I am a big advocate of arthroplasty, of just doing decompressions. I think there'll still be cases where you need to fuse the spine, but I try to minimize the number of levels that are fused. I think there's less money to take care of more patients. So I think we need to be careful and try to really do kind of the minimal operation to get the maximal benefit. So I try not to get everybody 100% better, but if I can get you 80, 90% better, I tell the patients, then that, is that acceptable? And most of them, that's what they want. They just want to feel better. And they know, you could do this huge operation and maybe make everything look better, but they're probably still not going to be 100% better. But, if you really concentrate on the 1 or 2 levels that are the most degenerative or the nerves are pinched the worst, then you'll get the maximum benefit and, the lowest complication rate and everything. I think the trend last decade was more to try to do more. And I think we need to start trying to do less to get better outcomes.
Oh, wonderful. Thank you. How do you see data and analytics evolving to help inform spine surgery in the future?
As much as I hate to admit it, I think, the we do need to know a little bit of the business side and have some responsibility in the cost of what we're doing. And we can't just do operations if the cost is prohibitive. So, what I've learned the most working with you is that, just the cost of the different technologies, and is there really a big difference between one versus the other? And if I can use something that is going to be a better price just for everybody, then, that there's a big advantage to that. And that's not always possible. There's certain times you want to use certain technologies that are more expensive, but, I think what happens is as we become, and again, I don't want to be a business expert, but as we become a little more savvy in the supplies we use and the cost of those supplies, I think the companies who supply those also need to make, they have to be more competitive in the business market, and they need to give prices to hospitals, and that is more reasonable. They can't just because they shouldn't be able to charge so much. So I think just us learning about how much things cost. And again, I don't want to negotiate the prices or anything like that, but I think it I think it's a good thing. And it's also good to look at our volumes and kind of what the cases we're doing, and as we get more outcomes and other things involved, it's important for us to really see that, make sure patients are doing well with what we do, because there is an expense for it. And, we want to make sure that we're not, we're kind of being good stewards of the money that's set aside for healthcare.
Sure. Thank you. The last question: what's something you've learned in your career that you wish you learned earlier on?
This one's really philosophical. I don't know about this one. I think the one thing that I try to stress with the residents is that, our job isn't to believe or not believe what the patient tells us. Our job is to believe everything they tell us and try to see if there's something we can do to help them, but also understand that if we don't think we can do anything to help them, then we shouldn't do anything at all. The hardest thing is to not operate on a patient when you're a surgeon, but it's really important to not operate if you really don't think you're going to help that patient. So the number one goal is to make the patient feel better, not to make the x-ray look better or the MRI look better, or to fill your surgical time. It's, can I really do something to help this patient? And then after that, you can talk about costs and all those other things.
Great. Thank you so much. We really appreciate you, taking the time to do this little series with us.